Good, mor- Good morning, doctors. It is important to note that history and physical examination findings generally are not sufficient enough to establish a firm diagnosis in a patient with acute abdominal pain. All patients with acute abdominal pain should have a complete blood count with a differential count and urinalysis. Determination of serum electrolytes is useful for assessing the patient's fluid and acid-base status, blood urea nitrogen and creatinine for assessing the renal function, and glucose levels for assessing the patient's metabolic state. Liver biochemical tests such as serum bilirubin, serum albumin, prothrombin, AST, ALT, and alkaline phosphatase, as well as serum amylase and lipase levels, should be ordered for patients with upper abdominal pain or with jaundice, as in our patient. Imaging studies would include abdominal ultrasound and CT scan. However, for our patient, ultrasound may be preferred because it is more cost effective, more readily available, and because our main differentials are not optimally imaged by CT scan.
Did your Remelin, did your book
Yes, doc.
mention anything about? So these are the only two imaging studies that your book mentioned for patients with acute medical abdomen.
Uh, Doc, for Schlesinger yes. However, there are secondary imaging modalities po. Would you like me to discuss them as well?
Uh, there's one imaging modality that should be the first imaging modality in most cases with acute medical abdomen. With acute abdomen. If you have a patient with severe abdominal pain, that Dr. Ruiz, you have a question?
Eh, No, you finish first, Stephen, and then
Yeah.
I'll.
Well, Dr. Velasco has typed in a question. Um, how about an X-ray of the abdomen, Remilin? Will that be helpful?
Ah, um, yes, doc.
Okay, Stephen, may I
And
intervene now?
Sige po, Doktora.
Just to put the point of Dr. Velasco here. Remelin,
yes po,
you
doctor.
saw the differential diagnosis that was given by Angelica, right?
Apo.
For acute abdomen, okay? In general, acute abdominal pain. So, what should be the approach if you are confronted with a patient with acute abdominal pain, with all the differentials that was mentioned? What should be the first task for you as the attending?
It would be to rule out po other diseases.
To rule out what particular disease?
Small bowel obstruction po, doc.
So, in other words, small bowel obstruction is a differential under acute surgical abdomen.
Ah, apo.
Okay? So, that's the first thing because if you delay surgery in this patient, then the prognosis becomes dismal and the prognosis became bad because you were not able to recognize that it is acute surgical abdomen. So that's the first thing that you will do. Now, in all of those differentials, small bowel obstruction, perforation, is there a simple test for you to do that right away? You can already tell us whether there is perforation or small bowel obstruction.
Uh, Consider use doing the fast.
Fast?
Uh,
Or you mean the ultrasound? Or
apo.
but if you don't have an ultrasound at the emergency room, like in UST hospital, there's no ultrasound in the emergency room. So is there another simple test? You look at Dr. Velasco's post now.
Ay, mm,
O si Christian, no? Christian
abdominal
also,
X-ray.
your simple abdominal X-ray or scout film of the
X-ray.
abdomen, no? Because as Christian
Okay
mentioned,
po.
you can already rule out or rule in. You can look for pneumoperitoneum, which will suggest bowel perforation, or what else? Can the simple X-ray tell you as a possible cause of the acute abdomen? Aside from looking for pneumoperitoneum,
I mm,
ano pa? If you have bowel obstruction, what will you see? What will you look for? Anybody in the scout film for small bowel obstruction?
or any level of obstruction in the intestinal
Yeah.
segments, what will happen? Sabi ni Juan, air
air
fluid
fluid
levels.
levels.
That's,
Okay.
that's correct. Okay,
Okay.
so the level of dilatation in the intestinal segments will also tell you where the obstruction is. So, kunyari, if you have obstruction in the cecum, then you would expect that the dilatation will be in the small intestinal segments. While if you have obstruction at the level of the rectum, then you would expect the large intestinal segments to be also dilated as well as your small intestinal segment. Okay.
Okay.
Sige, you may proceed, Remilin. Remilin, you may proceed.
Okay. Sige po. So, shown here is an approach to the urgent evaluation of abdominal pain, wherein specific complaints and physical examination findings are coupled with appropriate radiologic imaging. So, the examination begins with an assessment of the patient's appearance and airway, breathing, and circulation. So, if the patient shows prostration or is hemodynamically unstable, then we should proceed with resuscitation and urgent surgical consultation. We should also consider the focused abdominal sonogram for trauma examination and consider laparotomy due to the most likely diagnosis of perforated viscous, severe pancreatitis, ruptured spleen or hemoperitoneum, and ruptured abdominal aortic aneurysm. If not, we can consider perforated viscous diverticulitis, mesenteric infarction, and acute pancreatitis. If the patient presents with right lower quadrant pain with gradual onset, right lower quadrant tenderness, and localized rebound tenderness, then we should evaluate using appendix protocol CT for the diagnosis of appendicitis. For left lower quadrant pain, the most likely diagnosis is diverticulitis. In female patients, we should consider pelvic ultrasound or CT scan for the diagnosis of tubo-ovarian abscess, ovarian torsion, and ectopic pregnancy. If the patient presents with a gradual onset of right upper quadrant cramping pain, history of postprandial discomfort, then we should evaluate using right upper quadrant ultrasound with the most likely diagnosis of cholelithiasis, cholecystitis, bile duct obstruction, and cholangitis. If the patient presents with nausea, vomiting, obstipation, constipation, abdominal distension, or had prior surgery, then we should do an upright abdominal film or oral contrast CT for the diagnosis of small bowel obstruction. Um, if there is sudden onset diffuse pain, involuntary guarding, rebound tenderness, and peritonitis, then we should evaluate using upright abdominal film or oral contrast CT. So, given the patient's manifestations and risk factors, our differentials to be further discussed on are acute pancreatitis, acute cholangitis, and acute cholecystitis.
Remilin, can you go back to your
Yes po.
The algorithm that you showed. Just go back to
Yes
that
po.
slide. Just want to emphasize something.
Okay po, Doc.
One more slide there. So for the group, you can see here in the algorithm, it's very important that you have a clinical assessment already. So although we mentioned, okay, upright film, scout film of the abdomen can be helpful, it really depends on what your initial impression will be. Okay, so kung kunyari, right lower quadrant pain, your appendicitis or maybe pelvic problems in a female, then do the appropriate test for that. Okay, so it really depends on where the pain is located. What is your initial impression? Okay,
Thank you po.
sige, next student.
Hello. Can you hear me, guys? Hello.
Yes, we can hear you. We can hear you.
Okay, so good morning, guys. So today we'll be discussing the differentials for this case. So this is acute pancreatitis. So acute pancreatitis is the inflammatory disorder of the pancreas characterized by edema and necrosis. So the necrosis is reversible. So local data suggests that there is an annual incidence of acute pancreatitis of 25,300 cases. So pathologically, acute pancreatitis has two kinds. Interstitial edematous pancreatitis, which is described as having inflammation but no necrosis, while on the other hand, your necrotizing pancreatitis um, presents with both inflammation and necrosis. So, acute pancreatitis is caused by the following. So, the most common of these is the gallstones. So, gallstones, especially those that are smaller than 5 millimeters, have a greater risk of causing acute pancreatitis. So, So if you look in the picture on the right, smaller those stones smaller than 5 millimeters block the pancreatic duct, therefore impeding the flow of enzymes from the pancreas to the duodenum. Alcohol, on the other hand, is toxic to the assigner cells. So remember that the assigner cells contain the precursor of digestive enzyme trypsin, which is trypsinogen. Now, once these assigner cells are destroyed, it will release now the trypsinogen, causing autodigestion. There are other causes also um, of acute pancreatitis, which is those endoscopic retrograde cholangiopancreatography. Patients with high triglyceride levels. Some drugs could also cause acute pancreatitis, such as um, sulfonamides, uh, also the diuretics such as furosemide and thiazides. So smoking adds to the susceptibility of the patient of patients who are taking in alcohol. So it increases the risk of having acute pancreatitis. So these precipitating events will now lead to the pathogenesis of acute pancreatitis. Now, actually, what happens is that there is intrapancreatic activation of the trypsin into trypsinogen. Now, remember that trypsin is a digestive enzyme, so it will autodigest the pancreatic tissue and will lead to to yes po, Doc.
Baliktad, trypsinogen to trypsin.
Ay, trypsinogen to trypsin, Doc. Sorry po. Now autodigest the pancreas, which will now cause assigner cell injury. So as what I have mentioned a while ago, your assigner cells So again, this will be released into the pancreas, and again there will be activation, causing now a destructive inflammation, which is our second stage. So in the second stage of pancreatitis, there will be activation, chemoattraction, and sequestration of leukocytes and macrophages. The inflamed pancreas will also release cytokines, which will now cause edema, hemorrhage, necrosis, and vascular damage, among others. So vascular damage is leakage of these cytokines into the circulation, which will now bring us to the third stage. So the third stage, the effects of the cytokines on the distant organs. So the patient may present with systemic inflammatory response syndrome, acute respiratory distress syndrome, as well as if the patient presents with two or more of either the renal, cardiovascular, or the respiratory systems, the patient will now be considered as having multi-organ failure. So all of these will present in the patient as the following. So the most common presentation of acute pancreatitis in the patient is epigastric pain. So this pain is described as steady, boring, and it radiates to the back. So patients find relief as if they assume a knee chest position. Um, Another manifestation that may present this. Now, jaundice happens if the head of the pancreas, as you can see on your left, will be inflamed, and this head of the pancreas is edematous. It will now compress the intrapancreatic bile duct, causing now jaundice. Now, the patient could also present with nausea, vomiting, and abdominal distension. So these may appear in patients with gastric and intestinal hypomotility. The patient may also present with general signs of infections, low-grade fever, tachycardia, and if the patient suffers from um, mass third space losses and hemorrhage, the patient could present with could have shock and yes po doc.
The presence of low-grade fever, tachycardia doesn't mean infection. It can only mean inflammation. Okay? Not
Inflammation pala po doc.
necessarily
Yes po.
infection.
And also, Luis, regarding you mentioned that
Yes po.
the cause of jaundice can be due to the inflammation of the head of the pancreas, and that causes compression, right?
Yes po.
Um, is
Yes
there
po.
any other? Are there any other causes of jaundice? Let's say in a patient with pancreatitis. Yun lang ba? Is it just
Doc,
because of the inflammation of the head?
it's
Especially if
possible
you
din
think
po doc
about the
if the
etiology.
patient yes po, if the
Yes.
patient has cholelithiasis and it's the etiology of his pancreatitis po, it will cause din po blockage of the bile duct po. So it will cause
Cholelithiasis.
this din po.
Cholelithiasis causes
Choledoco.
blockage of the
Choled
choledoco. Okay, very good. So choledoco. Can pancreatic cancer also cause pancreatitis and as well as jaundice?
yes po.
That's also a possibility. Okay. Sige, proceed, Luis.
So So again, since there is hemorrhage in patients with acute pancreatitis, the patient may present with either the Turner sign or the Cullen sign. So the Turner sign, as you can see on your upper right side, it will present with a bluish discoloration of the flanks, while the Cullen sign will be on your lower right, which is the bluish discoloration of the periumbilical area. Um, Features will only point to a probable cause of acute pancreatitis, establishing a diagnosis of acute pancreatitis will now be discussed by John. Thank you.
Hello? Hello, hello. Hello. Hello, hello. Okay.
Proceed, proceed.
Okay.
We can
All
hear
right.
you.
So a diagnosis of acute pancreatitis can be made by establishing at least two of the three of the following criteria. The first criteria being a typical abdominal pain in the epigastrium that may radiate to the back. The second being a threefold or greater elevation in serum lipase or amylase with Okay, so usually if these are present, they are enough to establish a diagnosis. However, in cases where diagnostic criteria isn't met, for example, if a patient is unconscious or patients who do not improve within 48 to 72 hours, a CT scan may be used to find a may be used to find confirmatory findings of acute pancreatitis. The ultrasound may also be used in an emergency setting as the initial diagnostic imaging modality and most useful to evaluate for gallstone diseases and the pancreatic head. So now we move on to the various morphological features of acute pancreatitis that may be seen on CT in order to establish a diagnosis. Here, let me get the pointer. So for reference, we have the top left image, which is a normal pancreas seen on CT. So let us first look at image E, which is interstitial pancreatitis. Okay. Note that you can still see the pancreas, but the parenchyma is just a bit enhanced and there's no necrosis seen. Okay. Uh, Now we look at image A right over here. We see that you can see the pancreatic structure. However, you can see areas of non-enhancements or abnormal non-enhancements inside the pancreatic structure, which signify necrosis, thus making this a necrotizing pancreatitis. In image B, you can see a homogeneous collection with fluid density right over here, which is still confined by the peripancreatic fascial planes. But note that there's no necrosis seen in this. So these are findings of a pancreatic fluid collection, which can be seen in the first 4 weeks after onset of interstitial edematous pancreatitis. So moving on to image D, right over here, you can see, which is a pseudocyst, by the way. You can see the pseudocyst right over here, and this is a collection of pancreatic juice or fluid enclosed by a wall of fibrous tissue, and this usually occurs after 4 weeks of onset of interstitial edematous pancreatitis. Now we move on to image F over here, which is an acute necrotic collection. So what we see here is necrosis of the pancreas with no wall and a non-homogeneous collection in the peripancreatic tissue. Okay, and finally, image C, which is a walled-off necrosis. You can see heterogeneous fluid and non-fluid densities here with varying degrees of loculations encapsulated with a well-defined wall. Okay. Um, Now we move on to the clinical course, which is divided into two. Um, yes.
So there's a
Okay.
question, John, from Dr.
Uh,
Velasco.
so for initial diagnosis, the first two criteria is enough, po, doc. Um, Usually we request a CT scan if, for example, the patient hasn't improved after 48 to 72 hours. We don't usually order a CT scan before 48 hours because that may underestimate the amount of necrosis that can be seen.
Very good. Because if you look at your slide 2 regarding interstitial pancreatitis, there's actually no definite finding, pathognomonic
Okay.
finding that will tell you, okay, there's interstitial pancreatitis. Because the inflammation may not always necessarily lead to swelling in that area. Okay, so it may, in fact, your picture here appears to be a normal size pancreas. It's not even swollen. Okay, so it's really clinical diagnosis with your laboratory. Maybe going back to your um, note in terms of your amylase and lipase. I know it's not in your Harrison's, but I think you also look at Stay Messenger. Do we need to request for both amylase and lipase in patients suspected to have pancreatitis?
Um, you can
Yeah, no, may
request
messenger ka eh.
you can request for either one, doc. But lipase is usually the
So,
more specific.
so it's or, right? So it's not
Yes,
and.
yes,
So
yes, doc.
your Schlesinger, when you read your Schlesinger, it says that there's no advantage of getting both markers.
Yes,
It
but
it has to do with aside from lipase being more specific, it also has something to do with the the half-life of the enzymes. What is the half-life of amylase? What is the half-life of lipase? I mean, when does amylase start to decrease? When does lipase start to decrease?
oh, wait. As far as I can remember, I know if I remember correctly, I remember amylase increases first, and then lipase follows that
By
after.
a few hours. Actually,
Yeah,
by
by a
a
few.
few hours. So it's almost the same in terms of increase. But what is important there is when does amylase start to decrease and when does lipase start to decrease? Because if you have a patient, for example, who comes in with 1 day history of epigastric pain that you suspect to have pancreatitis versus, let's say, 5 days after the onset of epigastric pain, which one would you request? Will it be amylase? Will it be lipase?
So, doc, the decrease in amylase happens after 96
Oh,
hours, whereas um,
yeah.
lipase peaks. No, no, sorry. The
So
amylase
look at
peaks
look at
around
the
48
notes here.
hours. Yeah, amylase peaks around
Yeah.
48 hours, whereas lipase peaks at around 96 hours. So after peaking, that's when
Yes.
they would start to fall.
So given those two patients, which patient number one, 1 day history, patient number two, 5 day history. For patient number one, amylase or lipase?
Patient number one, amylase. Patient number two, lipase. Po, doc.
Well, patient number one, you can request for lipase, you can request
Oh,
for
you
amylase.
can, you can
Either
increase
of
it.
the two, right?
Yes, yes,
Uh-uh.
yes, yes, po, doc.
But patient number five, that's where your request will be different because
You,
at
you
five
don't
days,
have
you would
number
expect the
five
amylase might
to
come down. Dr. Ismail, yes?
you don't have patient number 5. You only have patient number 1 and
Oh,
patient number 2.
did I say patient number five? I said patient number two. I meant patient number two. The one with 5 day history. All right. Sige, John.
Okay, okay.
You may proceed.
So let's go on to slide 3. Okay, so now we move on to the clinical course, which is divided into two. So the early phase and the late phase. These phases describe the hospital course of the disease. So in the early phase of the disease, which is before 2 weeks, the severity is determined by clinical parameters rather than morphological features, which is why CT is usually not requested within the first 48 hours. Most patients experience systemic inflammatory response syndrome, which is an inflammatory state affecting various organs. In the case of acute pancreatitis, the top three most affected organs systems would be the respiratory system, cardiovascular system, and the renal system. So, in order to determine the presence of organ failure, the modified Marshall scoring system is used. Okay, you can see. Okay, I'll just show the scoring system real quick. So here's the modified Marshall scoring system. So you can see the various organ systems and their parameters. So basically, to simplify this table, a score of 2 or more defines the presence of organ failure. Okay, going back. Um, Now we have the late phase, which is after 2 weeks, and this requires imaging to evaluate for local complications such as necrotizing pancreatitis on CT, because necrosis prolongs hospitalization and if infected requires surgical intervention. Patients in this phase also require supportive measures, and it is important to note that in both early and late phase, the most important parameter of severity would be persistent organ failure. Okay. So the severity of acute pancreatitis is classified into three categories based on clinical and morphological findings. The severity Okay. The severity stratification of acute pancreatitis is important to identify patients with the highest morbidity. These patients may benefit from a timely transfer to the intensive care unit or tertiary referral centers. So we'll look at mild. So mild acute pancreatitis is defined to have no local complications or organ failure. And we will see the various complications on the next slide. So patients with mild acute pancreatitis usually get well within the first 3 to 7 days after treatment, and they may resume oral intake of foods if they feel hungry, have normal bowel function, and do not experience nausea or vomiting. Usually they Usually they initially start off ingesting a clear or full liquid diet and move on to low fat solid diets once in recovery. So moderately severe acute pancreatitis is defined as transient organ failure, which is less than 40 hours, or local or systemic complications, but in the absence of persistent organ failure. These patients may or may not have necrosis, but if fluid collection is present, it may prolong the hospitalization to more than a week. Okay, next. We have severe acute pancreatitis, and this is defined as persistent organ failure, which may involve one or more organs. So a CT or MRI is needed to assess for necrosis and other complications. But if local complications are found, then the management is dictated by clinical symptoms, evidence of infection, maturity of fluid collection, and the clinical stability. This is important to note at this stage, prophylactic antibiotics are not recommended. So this is the side of the complications of acute pancreatitis. It's divided into two, which is local and systemic. So as you can see here in local, as I mentioned earlier, there are you can see here they're also listed the complications which could be seen on CT, and there's also other complications such as ascites, thrombosis of blood vessels, bowel obstruction, obstructive jaundice. And systemic complications include the three in the modified Marshall scoring system: the pulmonary, cardiovascular, and renal. Also, hematologic, GI, metabolic, CNS, and fat necrosis.
Hello, magandang morning to everyone. In treating patients with acute pancreatitis, it is very important to take note that usually around 85 to 90% of the cases are self-limited and subside spontaneously. This is if the patient started treatment within 3 to 7 days and do not exhibit organ failure or complications. However, considerations such as accurate diagnosis and appropriate triage, as discussed previously, are highly important in managing such patients. Also, supportive care, proper monitoring for, and treatment of complications should be highlighted as well. After confirming diagnosis of acute pancreatitis, aggressive fluid resuscitation should be initiated. This will be discussed in the next slide. And administration of IV analgesics should be given to control abdominal pain. Etiologic search is important, and assessment of severity should be done serially. Safe aggressive fluid resuscitation is the most important intervention for patients with acute pancreatitis. You could use lactated ringer solution or normal saline solution for hydration, but LRS has been shown to decrease systemic inflammation and is proven by most studies as a better crystalloid than NSS. An IV bolus should be initiated at 15 to 20 milliliters per kilogram and should be followed by a 2 to 3 milliliters per kilogram per hour to maintain hydration. Adjunct therapy include NPO if there is nausea and vomiting. However, our patient did not present with nausea and vomiting. And administration of IV analgesics, our patient presented with severe pain, so we should initiate opioid therapy. But in considering opioid therapy, we must uh, go away from morphine because morphine is proven to cause sphincter OD spasm. And if the patient's pain subsides, we could give NSAIDs such as naproxen. Supplemental O2 at 2 liters via nasal cannula should be started as well. And it is uh, important to take note that prophylactic antibiotics are not recommended since they may induce opportunistic fungal infections and promote drug resistance. So for Dr. Chan, prognostication, I will discuss that on my last slide po. And targeted resuscitation strategy on the right will be with the measurement of hematocrit and BUN is done every 8 to 12 hours and is recommended to ensure adequacy of fluid resuscitation. So increasing levels of BUN during hospitalization signify inadequate hydration. And if the hematocrit and BUN levels in the first 24 hours decreases, it means that sufficient fluids are administered. Also, in the serial testing, if there is an increased level of hematocrit and BUN, we should do a repeat volume challenge of 2 liters bolus. And if the patient did not respond to that, we should transfer the patient to an ICU. So we should also exemplify caution for overhydration and especially among patients who are elderly and those with renal and cardiac problems. Yan. Another part of the management for the patient is his nutrition. Nutrition can be initiated according to the severity of his acute pancreatitis. After his pain resolves, he may be started on a low-fat solid diet. And if he presents with a more severe pancreatitis, enteral feeding should be initiated. Some advantages of enteral feeding are the following. It maintains gut barrier integrity, it limits bacterial translocation, and it is less expensive and has fewer complications compared to total parenteral nutrition. We should not delay feeding for so long because this may cause intolerance to enteral feeding and it may promote generalized ill use. Also, aggressive enteral feeding prior to adequate resuscitation may lead to non-occlusive mesenteric ischemia. So treatment based on etiology. So the most common cause of pancreatitis is gallstone. So a history of gallstone, amount of alcohol use, drug use, trauma, infection, and history of ERCP should be elicited from the patient. Although ERCP is a risk factor for acute pancreatitis, evidence of evidence of ascending cholangitis, such as increasing WBC and liver enzyme count, should prompt ERCP procedure within 24 to 48 hours of admission. There is a high risk of recurrence among patients with gallstone pancreatitis. Therefore, cholecystectomy should be considered within the admission, also known as an index cholecystectomy, or if it is done within 4 to 6 weeks discharge, also known as your interval cholecystectomy. Alternative for patients who are not surgical candidates would be endoscopic biliary sphincterotomy. Treatment for hypertriglyceridemia. Yes po, Doc.
Yeah, so Juan, what if you have gallstone pancreatitis but there's no ascending cholangitis? Do you do ERCP?
Doc, if there is no evidence po of gallstone po, we should proceed with the most important treatment po, which is the fluid resuscitation po. And
So the
ERCP should be,
ERCP, nawala ka. I did not hear what you said. Juan, I did not hear what you said. Oh, nawala yung mic mo.
hello, Doc. Hello, Doc.
Yeah, can you repeat what you said? With regards to
Doc,
patients with, uh
Doc, if there is no ano po, evidence of ascending cholangitis, we should refrain from doing ERCP po because it is an invasive maneuver po.
but the cause of the pancreatitis is your choledocholitis.
Yes po, Doc.
The difference there is with regards to the urgency of doing your ERCP. Pagka ascending cholangitis, you have to
Mm-hmm.
do it within 24 to 48 hours. But for patients with gallstone pancreatitis, where there's choledocholitis without cholangitis, it's still warranted to do your ERCP, but not right away. Dr. D.
Okay.
Yes, Chan. In fact, in your slides, you mentioned there ERCP has to be performed within 24 to 48 hours of admission. So we're just talking about the timing. But if the patient is in ascending cholangitis, you need to do ERCP right away. The reason for this
Okay
is
po.
that you don't want the pancreatitis, if there's any necrosis there, to do have bacteria there. You don't want to have an infected necrosis. The necrosis should be sterile. But if it becomes infected, it's more difficult to treat. Okay.
Okay po, Doc. Thank you. And going back, treatment of hypertriglyceridemia should include insulin and heparin. And if there is an evidence of high triglyceride levels greater than 1,000 milligrams per deciliter, we should consider plasmapheresis. So for post ERCP pancreatitis, usually we consider doing pancreatic duct stenting and administration of rectal indomethacin. For drug-induced pancreatitis, we should halt the medications that are proven to cause pancreatitis, such as mentioned a while ago, thiazide diuretics, furosemide, tetracyclines, and sulfa drugs. For the last part of prognosis. So these are some tools used for prognosing the case of the patient. So an example would be the bedside index of severity in acute pancreatitis or your BISAP score, wherein BUN, impaired mental status, systemic inflammatory response syndrome, age, and pleural effusion on radiography are given 1 point each. And this scoring is obtained in the first 24 hours or preferably on admission. Each criterion is allocated with a point, and a total score of 3 or more will reflect a higher risk in hospital mortality, around 15%. Other severity scoring systems include Ranson scoring, which is the most commonly used predictors of disease severity. And this test is usually done during the first 48 hours. Other tests include your acute physiology and chronic health evaluation or APACHE and your harmless acute pancreatitis score or HAPS, which could be done on early which could be done early on admission, and the HAPS has an accuracy over 90% and triages most patients away from the intensive care. So we consider the case related to acute pancreatitis because of the characteristic pain that the patient presents, which is a sudden severe epigastric pain, which is steady and boring in character. It is relieved by a characteristic position, which is the knee chest position, and it radiates to the interscapular area. Risk factors include alcohol binge, the recent alcohol binge that he had, and he is a smoker, and the amount of alcohol intake. He also has a family history of gallstones on the mother's side, and he is tachycardic and tachypneic with a low-grade fever. Icteric sclerae is also present, and his abdomen is slightly distended. He also has hypoactive bowel sounds and tender epigastrium. That's why we considered acute pancreatitis. Thank you. Yes po, Doc Chan.
Yes, Paolo. You mentioned both the alcohol and the gallstones. So, but in this case, what is the most likely reason for the pancreatitis?
The most common cause po is gallstone po. So most likely it's due to the gallstone po because it might indicate recurrence po because the patient already had an episode of acute pancreatitis before.
What was it acute pancreatitis or biliary
Or
colic?
sorry, it was a characteristic colic po.
Okay.
Sorry.
Okay, thank you.
Thank you.
Okay. Good morning, doctors. So moving on to the next differential of this case, which is acute cholangitis. also referred to as ascending cholangitis or acute bacterial cholangitis, is defined as acute inflammation and infection of the bile ducts resulting from a combination of biliary obstruction and bacterial growth in bile. So, among the complications of gallstones, it is considered that this is the most serious and lethal. So, as mentioned earlier, in acute cholangitis, there must be obstruction and infection. So, for obstruction, in approximately 85% of the cases, acute cholangitis is caused by a bile duct stone. Other known causes would be neoplasms, biliary strictures, parasitic infections, and congenital abnormalities. For infection, the most common bacterial species cultured would be gram-negative aerobes such as E. coli, Klebsiella, Pseudomonas, Proteus, and Enterococci. Anaerobes such as Bacteroides fragilis and Clostridium perfringens are also found in about 15% of cultured bile specimens. So it is important to note that obstruction is necessary but not sufficient to cause acute cholangitis. Again, as mentioned earlier, there must also be infection. So it is most likely that acute cholangitis occurs when a bile duct that already contains bacteria becomes obstructed. So although the exact mechanism is not clear, it is believed that the organism typically ascend from the duodenum. So here on your right is the illustration, so we can appreciate the anatomical relationship of these two structures. So also according to Schlesinger, this usually occurs in partial obstruction, which permits the reflux of bacteria from the duodenum into the bile duct, just like in choledocholithiasis or post-traumatic bile strictures. So this is the reason why only few patients develop cholangitis and obstructions caused by neoplasms, because in malignant obstruction, um, the obstruction is most often complete and thus less commonly permits reflux of bacteria from the duodenum to the bile duct.
That's an important
Yes,
distinction. That's
yes,
the exact reason why if you have malignant obstruction, it's not very common that you get cholangitis, but it's not 0%. You can
yes,
still
doc.
have cholangitis.
Uh,
Okay.
So here, here's the
Sorry,
pathogenesis of
Lisa. You
yes,
can
po,
have
doc.
you can also have infection even if there's malignant obstruction. It's just not so common because of
Yes, po.
hepatotic red, no? Not
Yes,
from
po.
the translocation from the um, duodenum, but rather it's from the system, hematogenous. For example, pneumonia, di ba?
Po. Yes, doc. Okay. So moving on, here's the pathogenesis of acute cholangitis. So given the condition that bile duct is contaminated and become obstructed, just like in the cases of choledocholithiasis, intraluminal pressure rises, and there is stasis of bile. So this bile stasis predisposes the bacteria in the bile to proliferate and cause infection. So as a result, the bile duct becomes inflamed, which will manifest as abdominal pain. So the further increase now in the intraluminal pressure due to inflammation causes the infected bile to regurgitate or ascend the biliary tree, eventually infecting the hepatic venous blood. So now the bacteremia will cause fever and chills, and the bile into the blood will cause jaundice. So that's all.
So for the symptoms of acute cholangitis, it mainly results from the inflammation, which is usually caused by the bile flow obstruction and bacterial infection, as mentioned earlier. So the hallmark presentation is commonly known as the Charcot's triad, which happens in sequential order. So it is composed of first the right upper quadrant pain, which happens in 90% of the patients. Jaundice happens in 80% of the patients, and 95% of the patients have a spiking fever of about 39 degrees Celsius, oftenly accompanied with chills. So this triad manifestation is only present in about 70% of the patient. So The figure shows obstruction in the bile duct, which caused the symptoms earlier, as well as the bacterial contamination. So the inflammation causes the right upper quadrant pain, and the jaundice is due to the obstruction since conjugated bilirubin, which was supposed to go to the bile caliculi, will now go to the hepatic duct and go to the hepatic venous circulation. Thus, patients can present with jaundice. And fever also results from the ascending hematogenous infection. So, in severe cholangitis, symptoms of toxicity can occur. So, in addition to the Charcot's triad, patients can have altered mental status as well as hypotension. This is known as the Raynaud's pentad. So, the Raynaud's pentad can indicate septicemia due to gram-negative organisms, as mentioned earlier. So, other clinical features of acute cholangitis can include nausea, vomiting, pruritus, dark colored urine, and also colic stools. So, in cholangitis, specifically the non-suppurative type, this typically responds rapidly in supportive measures and antibiotics, while the non-suppurative type of acute cholangitis may lead to complications such as mental confusion, septic shock, hepatic abscess, which can be brought about by bacteremia. So, if unless prompt intervention to relieve obstruction and drain the infected bile is done, mortality can reach up to 100%. So laboratory results can aid in identifying the biliary tract as the source of the infection. This will be further elaborated by the next reporter. Thank you.
For the diagnosis of acute cholangitis, there should be a high suspicion in patients presenting with fever, abdominal pain, and jaundice, or also known as the Charcot's triad. Laboratory tests such as complete blood count, C-reactive protein, serum bilirubin, liver enzymes, and blood culture can also aid in the diagnosis. Shown on the right side are the expected results in a patient with acute cholangitis. Leukocytosis with predominance of neutrophils, CRP of greater than or equal to 1 milligrams per deciliter, and an elevated serum bilirubin, ALP, and GGT, which signifies cholestasis. AST and ALT may also be elevated in the early stages, wherein pressure on the liver cells is the main feature and the lab results may resemble hepatitis. A positive blood culture for enteric organisms may also be seen. Imaging tests are also used in the diagnosis of acute cholangitis, and the principles are the same as those for choledocholitis. These are performed to look for bile duct dilatation or evidence of underlying etiology, such as a stone, stricture, or stent. In patients with Charcot's triad and abnormal liver tests, we proceed directly to ERCP to confirm the diagnosis and also provide biliary drainage. If ERCP is unsuccessful, percutaneous transhepatic cholangiography can be performed. In all other patients with suspected acute cholangitis, we perform abdominal ultrasound to look for bile duct dilatation and stones. If the abnormal of if the abdominal ultrasound is normal, abdominal CT scan is performed to exclude other causes. If the abdominal ultrasound and CT are both normal in a patient with suspected acute cholangitis, we perform MRCP, which has a higher diagnostic accuracy
Dr. D,
in identifying the yes,
Yan,
Doc.
Jillian, Dr. D
mentioned
has a question.
you mentioned kasi, di ba, that abdominal ultrasound, you look for dilated ducts and stones. What if during ultrasound you only saw dilated ducts? Would you still request for ERCP without stone?
Yes, Doc. Since ultrasound is not a sensitive as CT scan for looking for stones.
And the initial premise is that you have a patient with cholangitis.
Yes, doc. A diagnosis of acute cholangitis is made if a patient has evidence of systemic inflammation with one of the following: fever and/or shaking chills, laboratory evidence of an inflammatory response such as leukocytosis and elevated CRP. In addition, both of the following must be present: evidence of cholestasis reflected in the elevated bilirubin (ALP or GGT), and imaging with biliary dilatation or evidence of the underlying etiology, such as a stone stricture or stent.
Roman, Roman, it's your turn. Is Roman here? Ibay. I don't see him in the presenters. Oh, hindi siya naka-login, no? Ah, okay.
Connection problems lang daw po.
Connection problems. Okay. Dr. Ismail.
Yeah, while you're trying to connect, let me just point out the proper pronunciation since we started that with Corbusier. Charcot. It's not Charcot. It is French. The original article by Dr. Charcot, Les maladies de Charcot.
And it's Courvoisier.
Hello po, doctors. Can you hear
Courvoisier.
me?
Yeah, we can hear you.
Okay po, doc. So, for the treatment of acute cholangitis, I will just discuss in running the approach to Harrison's because it was already previously discussed by the first BGD. So, for Harrison's, it's important to classify the patient as whether he has non-suppurative or suppurative acute cholangitis. Non-suppurative acute cholangitis is usually responsive to antibiotic therapy and supportive management, and it will also require drainage right after that management. Then for suppurative acute cholangitis, usually that's an emergency case, so it has to be attended right away, and surgical intervention will have to be the mainstay of treatment. For the next approach, which is based from Schlesinger, there are five components in the approach, which is confirmation, pharmacologic therapy, assessment, and intervention. So according to Schlesinger, it is important to confirm the etiology by blood culture. A positive gram-negative bacteria culture and anaerobic culture usually warrants immediate antibiotic therapy. So next slide. So pharmacologic treatment based from Schlesinger is for mild cases, a single drug therapy should be given. IV cefoxitin 2 grams every 6 to 8 hours following the antibiotic stewardship. Usually it's given because there is a there is a gram-positive and gram-negative coverage and anaerobic coverage. For severe cases, based from Schlesinger, multiple drug therapy is usually the modality of choice to prevent resistance, according to the epidemiology, severe cases of acute cholangitis usually have high cases of treatment failure. the first choice of multiple drug therapy is gentamicin, ampicillin, metronidazole. Gentamicin has a strong gram-negative coverage. Ampicillin aids in the coverage for enterococci, and metronidazole usually has a strong gram-negative with an enhanced anaerobic coverage of bacteria. For broad-spectrum antibiotics, IV piperacillin tazobactam may also be given in case gentamicin, ampicillin, and metronidazole don't really work. And this is usually for all types of bacteria, gram-positive, gram-negative, anaerobic, aerobic. And this may also aid in the treatment of bacteria that may have beta-lactamases. IV meropenem can usually be given for multiple drug-resistant bacteria, and it is usually the last line for antibiotic therapy, and it is given 1 gram every 8 hours. So it is important to note that on the next slide, right after you give pharmacologic therapy, you'd have to assess the signs and symptoms of the patient. This will determine if you'd need further intervention or therapy, or you just stick to the antibiotics. So the signs and symptoms should improve within 6 to 12 hours, accompanied with infection control within 2 to 3 days. That would, if they improve, usually you'd have to stick to antibiotic therapy. But if there's no improvement of signs and symptoms in the past 6 to 12 hours, and there will be persistence of hypotension and bacteremia, surgical intervention will be necessary. So for the surgical management, the gold standard is usually endoscopic retrograde cholangiopancreatography with endoscopic sphincterotomy. Usually this is the preferred initial treatment after antibiotic treatment failure. And it was already established in Schlesinger that it is safe and it has diagnostic and therapeutic capabilities. On a clarification, ERCP plus sphincterectomy can be used for elective procedures for mild cases of acute cholangitis based from Schlesinger. It is also important to note that you'd have to treat the underlying causes. So you'd have to remove the stone, and you can also do bilioenteric bypass procedures to preserve the flow of the bile. So if we were to relate the yes po, erupted po, yes po. If you relate this to the case, the possible reason why acute cholangitis can be yes po, doc. Doc.
Dr. Chan, you raise your hand.
Yes. I was about to say that ERCP is not a surgical procedure. It is an endoscopic procedure. You place
Yes
it
po,
under
doc.
surgical. Typographical error. It's not surgical.
Yes po, doc. Okay, noted po, doc. Thank you for the correction. So to continue the presentation, in relation to the case, consider acute cholangitis as a differential because the patient presented with epigastric pain and the patient has a risk factor of alcohol binge drinking, which can predispose to gallstones. And the patient also has strong family history of gallstones. The patient also presented with fever and icteric sclerosis. So this can be in um, this can also satisfy a part of the chart described, which is fever, jaundice, and abdominal pain. Although abdominal pain is usually preferred to be in the right upper quadrant based from Schlesinger. And there could be a possibility that there could be bile flow obstruction due to gallstones because of his risk factors and because of his alcohol binge drinking. So that's it. That's it. Next slide.
Okay.
Thank you, Doc.
Good morning, everyone. The last differential for today is the acute cholecystitis.
Dr.
Stephen,
D.
di ba he has
Yep.
to tell us why he thinks this is acute cholangitis?
Yeah, the last slide that he presented,
Okay.
he
Okay.
discussed it.
Okay.
Okay na
Sige,
po.
next group. Next group.
For the last differential, it is the acute cholecystitis. Acute cholecystitis is an acute inflammation of the gallbladder wall. It is the most common complication of gallstone disease. Inflammatory response is evoked by three factors. The first one is the mechanical inflammation. Increased intraluminal pressure and distension leads to the ischemia of the gallbladder mucosa and wall. The second one is the chemical inflammation, which is the release of lysolecithin and other tissue factors. The last one is the bacterial inflammation, and the most common pathogens of this one is E. coli, Klebsiella, Streptococcus, and Clostridium. For the calculus cholecystitis, the obstruction is caused by a gallstone in the cystic duct, gallbladder neck, and the Hartmann's pouch. Uh, Doc, she will present the clinical manifestations po. Okay, for the calculus cholecystitis, the obstruction is caused by a gallstone in the cystic duct, gallbladder neck, and the Hartmann's pouch, which is an outpouching of the wall of the gallbladder at the junction of the neck of the gallbladder and the cystic duct. This is usually seen in young and healthy women. The calculus cholecystitis is an inflamed gallbladder wall without the gallstones. Biliary sludge might be responsible for this. People with the following conditions have an increased risk of having a calculus cholecystitis. The conditions are prolonged fasting, postoperative patients, and hospitalized trauma and burn patients. This is also more common in the elderly male patients. Emphysematous cholecystitis starts with either a calculus or calculus cholecystitis followed by the ischemia or gangrene of the gallbladder wall. There is also an infection by gas-producing organisms such as Clostridium and aerobes like E. coli. For the pathogenesis of the calculus cholecystitis, this is the gallstone obstructing the cystic duct, and these are the mucosal sloughing and the inflamed and congested wall of the gallbladder. Acute calculus cholecystitis is the most common complication of gallstone disease. It generally occurs when a, when a stone becomes embedded in the cystic duct and causes chronic obstruction, rather than the transient obstruction as seen in biliary pain. Stasis of bile within the gallbladder lumen results in the damage of the gallbladder mucosa, with consequent release of intracellular enzymes and activation of a cascade of inflammatory mediators. This would lead to the distension of the gallbladder, and as the gallbladder becomes distended, blood flow and lymphatic drainage are compromised, leading to mucosal ischemia and necrosis. For the pathogenesis of acalculous cholecystitis, most cases of acute acalculous cholecystitis occur in the setting of prolonged fasting, immobility, and hemodynamic instability. The gallbladder epithelium is exposed continuously to one of the most noxious agents in the body, a concentrated solution of bile acid detergent. In the course of a normal day, the gallbladder empties the concentrated bile several times and is replenished with dilute and presumably less noxious hepatic bile. With prolonged fasting, the gallbladder is not stimulated by cholecystokinin to empty, and concentrated bile stagnates in the gallbladder lumen. In addition, the gallbladder epithelium has relatively high metabolic energy requirements in order to absorb electrolytes and water from the bile. Therefore, an immobile fasting patient with splanchnic vasoconstriction, ischemia, and chemical injury to the gallbladder epithelium may occur. For the pathogenesis of emphysematous cholecystitis, as seen in the picture, this is the air fluid level. This here is the fluid, and this one is the air inside the gallbladder. Emphysematous Yes, Doc.
Michelle, it's not an air fluid level. Okay, it's just
Oh,
fluid
okay.
surrounding. It is either fluid or gas that is surrounding the gallbladder. Okay,
Okay po. Okay po, Doc.
air fluid level refers to something else. Thank you.
As in, like, small bowel obstruction po, Doc. Thank you po, Doc.
Go ahead. Go ahead.
Uh, okay po. For the emphysematous cholecystitis, it starts with either a calculus or calculus cholecystitis. Impaction of stones in the cystic duct leads to the localized edema of the gallbladder wall, which contributes to the vascular compromise of the gallbladder. Nevertheless, emphysematous cholecystitis in the presence of calculus cholecystitis is also well established. The microorganisms commonly isolated are the Clostridium species, E. coli, and Klebsiella. Although the intramural gas observed in the patients with emphysematous cholecystitis seems to result from gas-forming bacteria, whether these bacteria represent the primary cause of the disorder or are secondary invaders remains unclear. For the clinical manifestations, this will present
Acute cholecystitis initially presents as an attack of biliary pain that progressively worsens. However, in majority of patients, it resolves spontaneously. As the pain progresses, it becomes more generalized in the right upper quadrant of the abdomen, which then radiates in the interscapular area, right scapula or shoulder. Yes po, Doc.
So where does the pain start? Is it starting in the right upper abdomen right away?
Um, in the epigastrium po.
Epigastrium. Because the pain usually is visceral first, right? So
Yes
it's
po.
midline. Okay.
Yes po. Other clinical manifestations would include low-grade fever, nausea, vomiting, and anorexia, and jaundice. Jaundice is not is unusually early in the course of the disease, but it is present only if the bile ducts and the adjacent lymph nodes are subjected to inflammatory changes. An enlarged, tense gallbladder is also palpable in about 25 to 50% of patients, and a characteristic sign present in patients with cholecystitis is Murphy's sign. um, the patient is asked to exhale, and then the examiner places the hand below the costal margin in the right upper
Exhale?
quadrant. Po.
You're saying the patient has to exhale to set
Inhale po.
Murphy's sign?
The patient po
Inhale.
with
Why
inhale,
inhale?
yes.
Why not
For
exhale? Why inhale?
um for the ano po, the gallbladder po to descend, and it will touch po the hand of the examiner.
Okay, so it's because when you inhale, the expansion of your pleural cavity will push down your your liver and your gallbladder down.
Yes po.
Okay.
Okay po, doctor. And then, an increased pain and inspiratory arrest upon subcostal palpation is positive for Murphy's sign, and it is suggestive of peritoneal inflammation. Symptoms of paralytic ill use, such as abdominal distension and hypoactive bowel sounds, are also present. For the complications, acute cholecystitis, since it is an inflammation of the gallbladder wall, or persistent obstruction of the cystic duct by a stone or a biliary sludge could lead to either empyema or mucocele or hydrops. With empyema of the gallbladder, yes po,
Elizabeth, are you going to discuss diagnosis or iba yung magdi-discuss ng diagnosis? Kasi
different
you're already
presenter
in
po.
complications. Different presenter. Okay.
Yes po, diagnosis and treatment po for the next presenter.
Okay, okay.
Okay po. The empyema of the gallbladder will result from the stagnant bile
getting super infected by past-forming bacteria. Patient will manifest with high fever, severe right upper quadrant pain, and leukocytosis. And this is managed with emergency surgery and use of antibiotics. For mucocil or hydrops, the um, mucosal epithelial cells will produce either mucus, thus mucocil, and clear transudate, hence hydrops, which causes the obstruction of the gallbladder lumen to be progressively distended. Patients are usually asymptomatic, however, majority of patients, there is a palpable non-tender mass, as what mentioned earlier po, the hydrops, and it is managed by cholecystectomy. Next is the inflammation and adhesion formation in the adjacent sides of the gallbladder. This would lead to the formation of fistula, most common in the duodenum, and large stones of more than 2.5 centimeters will predispose to fistula formation. And these fistulas, specifically cholecystoenteric fistulas, may serve as passageway for the gallstones to lodge into the ileocecal valve, since it is the narrowest portion of the GI tract. This will cause obstruction and later on ileus. Um, for fistulas, it is managed by either cholecystectomy, CBD exploration, or even closure of the fistulous tract. However, for gastric ileus, laparotomy with stone extraction is warranted. Um, Ischemia of the gallbladder wall and tissue necrosis would lead to gangrene and perforation. And I have also included emphysematous cholecystitis as part of complications since it is mentioned in Schlesinger. Gangrene will predispose the gallbladder to perforation, which could either be a local or a free perforation. For local perforation, it leads to abscess formation due to the superinfection of the bacteria, and free perforation would cause generalized peritonitis. Both of these are managed with cholecystectomy abscess. And lastly, for the last line, sufficient concentration of calcium salts, either in the lumen or in the gallbladder wall, would lead to the formation of limy bile or porcelain gallbladder. In the limy bile or milk of calcium bile, the gallbladder wall, the gallbladder lumen may produce a diffuse hazy opacification or layering effect that is visualized under plain abdominal radiography. And for porcelain gallbladder, abdominal CT scan would reveal, as you can see here, a calcified rim with a dark central bile-filled region. Both of this will be managed with cholecystectomy. And it is important to take note that porcelain gallbladder is highly progresses to gallbladder carcinoma. And then for the last complication, the Merizi syndrome is due to the impacted stone in the cystic duct and gallbladder neck. These would cause CBD compression, obstruction, and eventually would manifest in the patient as jaundice. And it is managed by, yes po, Doc.
Elizabeth,
Yes po.
Mirichi. Mirichi, si
Mirichi.
Tiger. Okay?
Okay po. Okay
Mirichi.
po. We're learning a
Security.
lot of terminologies po. Yes po, Doc. Thank you po. Mirichi syndrome. It is managed po by surgical intervention. Thank you po.
Hello?
Yes, we can hear you.
So, hi everything. Hi everyone po pala. So, I'll discuss the diagnosis. So, the diagnosis of acute cholecystitis is usually made on the basis of a characteristic history and physical examination. So, the triad of sudden onset of right upper quadrant tenderness, fever, and leukocytosis is highly suggestive. Typically, the leukocytosis is in the range of 10,000 to 15,000 cells per microliter. And for the labs, The serum bilirubin is mildly elevated, and there's also a modest elevation of the serum aminotransferases. So the first diagnostic test I'll be discussing is ultrasound. So the ultrasound findings of acute cholecystitis in ultrasound are the pericholecystic fluid, shown by the yellow arrow, the gallbladder wall thickening, shown by the arrowheads, and dilatation of the ducts, which are not clearly shown in this picture. Um, sometimes you
So,
can also appreciate.
Leandre,
Yes,
do
doc.
you know what is uh, the the measurement for gallbladder wall? What is the normal um,
Um,
thickness?
less than 4 millimeters, po, doc.
4 or less. So
Yes,
anything that's more than 4 millimeters, that's
yes, doc.
okay. Is
Um,
acoustic shadowing, um, part of the diagnosis for cholecystitis? Kasi you're saying this is
no po,
on
doc.
cholecystitis, right?
No po, doc. Hindi po siya kasama sa findings po.
Kasi
Common cause lang po kasi ang gallstones for acute cholecystitis.
kasi you can have fatal cholecystitis, right?
Yeah.
There's one more thing that you can do on ultrasound in terms of diagnosing cholecystitis. What is that?
The sonographic Murphy sign po, doc.
Okay, so can you expound on sonographic Murphy sign?
So aside from the ultrasound findings, a
Do you
more
know what that
specific finding, doc? See,
Yeah, can you expound on that?
sorry
The
po.
sonographic Murphys?
So it is usually elicited by the ultrasonographer or the doctor, which elicits the focal gallbladder tenderness under the transducer of the ultrasound. So the sonographic Murphy sign is usually operator dependent and requires an alert patient. So the presence of the sign has a positive predictive value of more than 90%. So this is when you um, press the transducer on the right upper quadrant, which elicits the pain from the patient. Doc.
So the main difference with your Murphy sign on PE and your ultrasonographic Murphy sign is that on your PE, you're actually guessing where the gallbladder is, and you're trying to insinuate your finger so that it will be when you inhale, the gallbladder will touch your finger. Now, sonographic Murphy sign, since you actually visualize where the gallbladder is, then the ultrasound probe will serve as like your finger, where you can really direct it towards the gallbladder, and that will be more specific. Okay,
Yes, Doc.
all right.
So the second diagnostic test is the HEDA scan. So the HEDA scan is a radionuclide imaging test of the gallbladder and biliary tract. It is most useful for evaluating patients with suspected acute cholecystitis. So this can diagnose cholecystitis rapidly within 60 to 90 minutes by observing the patency of the cystic duct. So the procedure is done by injecting the hydroxyl immunodiacetic acid, or the HEDA. It's inserted intravenously, which is taken up by the liver and biliary tree. So a positive HEDA scan is shown on the right side. I'll use the pointer. Um, when the gallbladder and the bile ducts are not able to take up the HEDA over here in within the 30-minute to the 60-minute mark. So the left picture is just a picture of a normal HEDA scan when a gallbladder takes up the dye. So for
So
the
basically, yeah, just to expound on that. So basically, your HEDA scan really, kumbaga, it's trying to trace the physiologic flow of your bile. So in a normal individual, when the liver produces your bile, it should flow through your common hepatic duct towards your common bile duct. But since your sphincter of OD is closed, then there's increase in pressure there, and then your bile will now go into the area of least lesser pressure, and that will be through your valves of Oyster into your gallbladder, right? So that in patients with cholecystitis, whether it's calculus or acalculus, there will be an obstruction there, and the bile will not flow into your gallbladder.
Yes,
Okay,
Milo.
sige. All right.
So lastly, for the last diagnosis, it is the CT scan. So the CT scan is not usually warranted. So it is usually used for detection of complications of cholecystitis. And this is the photo on the right is a photo from Schlesinger, which shows a complication of emphysematous cholecystitis, which is the gas pockets in the shown by the yellow arrow. So the CT scans can also be done if ultrasound is not cannot be done, such as the patient having abnormal obesity or ascites. Um, so we move on into the treatment of of acute cholecystitis. So lastly, so there are two ways of managing acute cholecystitis: medical and surgical. So patients treated medically are given meperidine or NSAIDs for analgesia, IV antibiotic therapy, which will address the common organisms, E. coli, Klebsiella, Streptococcus, which they are given piperacillin plus tazobactam, ceftriaxone plus metronidazole, or levofloxacin plus metronidazole. And in severe cases, imipenem or meropenem may be given. Now, it is important to note that 75% of patients who are treated medically have remission of symptoms within 2 to 7 days. And in 25% of patients, complications occur, which prompts surgical treatment, which leads us to the surgical treatment side of acute cholecystitis. That's why it is the mainstay of treatment. So, so for urgent cholecystectomy or cholecystostomy, are for patients who develop complications of acute cholecystitis. So, and for early elective laparoscopic cholecystectomy, are for patients with uncomplicated cholecystitis. And there's also the delayed laparoscopic cholecystectomy for patients with doubts in diagnosis of acute cholecystitis and or a medical condition which imposes risk in early surgery. And lastly, we have cholecystostomy and tube drainage of the gallbladder for seriously ill patients or older patients. And afterwards, elective cholecystectomy can be done. So, um, we considered acute cholecystitis because of the pain of the patient, shown by the pain lasting more than 6 hours or 48 hours. The low grade fever. Yes, Dr. Ruiz. Sorry.
Yeah. What pain are you referring to?
Uh, biliary colic pain po, Doc.
Oh, so if it's biliary colic, is it for acute cholecystitis per se?
Um,
What does the presence of biliary colic denote or imply? Presence of? Is it cholecystitis?
uh, gallbladder ano po, pain po in general.
Anong gallbladder pain?
Um,
Cholecystitis, gallbladder pain din. Pag sinabing biliary colic, it denotes presence of stones, di ba?
okay, yes.
Oh, so what is now the correlation or the association of stone and acute cholecystitis?
Um, so the patient showed jaundice and also had risk factors such as gallstones from the mother's
No,
side of the
my question is, why will you consider as a support for your diagnosis in acute cholecystitis the presence of biliary colic? Ano bang relationship nung stone at saka cholecystitis? Ito
the
din
most
yung the most
the most common cause of cholecystitis is stone po, Doc.
Okay. So, dapat ganun yung context nung understanding nyo.
Yes
Ha?
po, Doc.
So, the presence of the biliary colic tells you that more likely there's a stone, and the most common cause of cholecystitis is presence of stones. Okay?
Yes, yes po, Doc.
Sige.
So, I'll hand the mic to Ella po for the final diagnosis.
Okay. So,
Okay.
again, doctors, stated here are the patient's signs and symptoms as well as the clinical manifestations of the discussed differentials. We primarily considered acute pancreatitis because of the patient's epigastric pain with sudden onset, which is steady and boring and radiating to the back. The pain was also noted to be more intense when supine and alleviated by sitting with the trunk flexed and knees drawn up. The patient presented with abdominal tenderness and muscle rigidity, bowel sounds diminished. Risk factors would include the gallstones, the patient being a smoker, and also the intake of alcohol. Associated symptoms present include abdominal distension and jaundice. We also considered acute cholangitis because of the risk factors of gallstones
Maybe
and alcohol.
maybe summarize and what is your final diagnosis? Because you're
Okay po,
saying
Doc.
the three diagnoses.
Apa.
What will be the most
Okay.
diagnosis in this patient?
So given this summary, the most likely diagnosis po of the patient is acute pancreatitis.
And the reason being,
And
so
the
so
reason
that's
is
why,
because, yes po, Doc.
yeah, sige.
Ah, Ayun po, Doc, because of the patient presenting with the epigastric pain with sudden onset, which was steady and boring, radiating to the back, and it was noted to be
Mm-hmm.
more intense when supine and alleviated by sitting with the trunk flex and knees drawn up
Okay.
po.
And
And
then
the
risk
patient
factors for
also,
that?
risk factors would include the patient being a smoker, the intake of alcohol, and gallstones po.
Okay. Sige. Very good.
Thank you, Doc.
Very good. I think if there are no more questions, we'll adjourn the BGD and then uh, meet again for the SGD. Okay. Congrats. Dr. Chan.